Welcome to today's comprehensive overview of asthma management for nursing professionals. I'm Fireside Facts, and over the next 15 minutes, we'll explore the pathophysiology, assessment, and evidence-based nursing interventions for patients with asthma. Whether you're preparing for clinicals or looking to refresh your knowledge, this video will equip you with essential skills for providing excellent respiratory care. Let's start with the fundamentals. Asthma is a chronic inflammatory disease of the airways characterized by reversible airway obstruction, airway hyperresponsiveness, and underlying inflammation. But what does this actually mean for your patients? In a healthy airway, smooth muscle surrounds the bronchioles, allowing for normal expansion and contraction. The airway lining is thin, and mucus production is minimal and easily cleared. In asthma, three key changes occur, what we call the inflammatory triad. First, bronchospasm. The smooth muscle around the airways constricts, narrowing the passageway for airflow. Second, mucosal edema. The airway lining becomes swollen and inflamed, further reducing the diameter. Third, increased mucus production. Thick, sticky mucus clogs the already narrowed airways. Asthma affects approximately 25 million Americans, including 6 million children. As nurses, you'll encounter asthma patients across all care settings, from emergency departments to school health offices. Understanding triggers is crucial for patient education. Common triggers include allergic triggers, dust mites, pet dander, pollen, mold irritant triggers, smoke, strong odors, air pollution, exercise-induced triggers, physical activity, especially in cold air, infectious triggers, viral respiratory infections, emotional triggers, stress, anxiety, strong emotions, weather triggers, cold air, humidity changes, barometric pressure. The National Heart, Lung, and Blood Institute classifies asthma into 4 severity levels, which guide treatment decisions. Intermittent asthma, symptoms less than 2 days per week. Nighttime awakening, less than 2 times per month. Normal lung function between episodes, mild persistent. Symptoms 2-6 days per week. Nighttime awakening 3-4 times per month. Minor limitation in daily activities. Moderate persistent. Daily symptoms, nighttime awakening more than once weekly. Some limitation in daily activities, severe persistent. Continuous symptoms, frequent nighttime awakening, extremely limited daily activities. We also recognize different asthma phenotypes. Allergic asthma, most common, typically develops in childhood. Non-allergic asthma, often develops in adulthood, may be triggered by infections. Exercise-induced asthma. Symptoms occur specifically with physical activity, occupational asthma, triggered by workplace exposures. Now let's examine what happens at the cellular level. Understanding this pathophysiology is crucial for comprehending why our interventions work. When a susceptible individual encounters a trigger, mast cells in the airways release inflammatory mediators, including histamine, leukotrienes, and prostaglandins. This creates the immediate inflammatory response. This triggers a cascade involving eosinophils, neutrophils, and T lymphocytes. These cells release additional inflammatory mediators, perpetuating the inflammatory cycle. Smooth muscle hypertrophy and hyperplasia. Over time, Chronic inflammation leads to structural changes called airway remodeling, smooth muscle hypertrophy and hyperplasia, increased mucus gland size and number, basement membrane thickening, collagen deposition. This explains why asthma has both immediate and delayed responses. The early phase occurs within minutes and involves bronchospasm. The late phase, occurring 4–12 hours later, involves sustained inflammation and can be more difficult to treat. Effective asthma management begins with thorough assessment. Let's break this down systematically. Primary assessment, the ABCs. Airway. Is the patient able to speak in full sentences? Whispered speech or inability to speak indicates severe obstruction. Breathing. Observe respiratory rate, depth, and effort. Look for use of accessory muscles, pursed lip breathing, tripod positioning circulation. Check pulse rate and quality. Pulsus paradoxus greater than 10 mm/G suggests severe obstruction. Respiratory assessment, auscultation. Listen for wheezing, but remember, absence of wheezing in a distressed patient may indicate severe obstruction. Peak flow measurement. Compare to patient's personal best oxygen saturation. Normal values don't rule out significant obstruction. Severity indicators. Mild exacerbation, speaks in sentences. Walks normally, respiratory rate slightly elevated. Wheeze only on expiration, moderate exacerbation. Speaks in phrases, prefers sitting to lying. Respiratory rate increased. Wheeze on inspiration and expiration. Severe exacerbation. Speaks in words only. Sits upright. Leans forward. Respiratory rate 30. Wheeze throughout respiratory cycle. Life-threatening. Unable to speak. Exhausted appearance. Paradoxical chest movement. Silent chest on. Auskultation. Onset and duration of current symptoms. Trigger identification, medication use, and effectiveness. Previous hospitalizations or intubations. Personal best peak flow values. Asthma medications fall into two main categories: quick, relief medications for acute symptoms, and long-term control medications for ongoing management. Quick relief medications. Short-acting bêta-2 agonistes, SABAS. Exemple: albuterol, levalbuterol. Mechanism: relax smooth muscle in airways. Onset: 5–15 minutes. Duration: 4–6 hours. Nursing considerations: monitor heart rate, assess for tremor, educate on proper inhaler technique. Anticholinergics, example, ipratropium bromide mechanism, block acetylcholine receptors, often combined with SABAs for synergistic effect. Nursing considerations: monitor for dry mouth, assess for improvement in 30–60 minutes. Long-term control medications: inhaled corticosteroids, ICS. Examples: fluticasone, budesonide, beclomethasone. Mechanism: reduce airway inflammation. Nursing considerations: teach proper technique, emphasize daily use. Monitor for oral thrush, long-acting beta-2 agonists, LABAs. Examples: salmeterol, formoterol, never used alone, always combined with ICS. Duration: 12 hours, stepwise approach. Treatment follows a stepwise approach based on asthma severity. Step 1. SABA as needed. Step 2. Low dose ECS. Step 3. Low dose ECS. Là-bas combination step 4. Medium dose ECS. Là-bas step 5. High dose ECS. Là-bas plus additional controller step 6. Add oral corticosteroids. Section 6. Nursing interventions. Now, let's focus on specific nursing interventions that can significantly impact patient outcomes. Medication administration. Metered dose inhalers, MDIs. Remove cap and shake inhaler. Exhale completely. Create seal around mouthpiece. Press canister while inhaling slowly and deeply. Hold breath for 10 seconds. Wait 1 minute between puffs if multiple doses. Dry powder inhalers. No shaking required. Requires rapid, forceful inspiration. Patient must be able to generate adequate inspiratory flow. Nebulizers. Ideal for young children or patients in severe distress. Ensure proper mask fit monitor for side effects. During treatment, positioning. High Fowler's position to maximize chest expansion, tripod position if patient prefers. Avoid supine positioning during acute episodes, ongoing monitoring, respiratory rate, effort every 15 minutes during acute episode, peak flow measurements, oxygen, saturation, heart rate, and blood pressure, level of consciousness and anxiety. Environmental management. Remove or minimize triggers. Maintain optimal humidity 30–50%. Ensure smoke-free environment. Regular cleaning to reduce allergens. Patient education. Proper inhaler technique, return demonstration is essential. Trigger identification and avoidance. When to seek emergency. Care Asthma Action Plan. Development, peak flow monitoring at home, emergency management. Recognizing and managing severe asthma exacerbations can be life-saving. Animation, emergency assessment sequence. Immediate actions. Assess severity using the indicators we discussed. Administer oxygen to maintain saturation 90%. Give bronchodilators, typically albuterol via nebulizer. Prepare for systemic steroids if moderate to severe emergency medications. Albuterol 2.5 mg via nebulizer every 20 minutes for 3 doses. Ipratropium 0.5 mg with albuterol for severe cases. Systemic steroids. Prednisone 1–2 mg/kg for children, 40–80 mg for adults. Magnesium sulfate. For severe cases not responding to initial treatment, red flag symptoms when to escalate. Peak flow 50% of personal best. No improvement after 3 nebulizer. Treatments. Inability to speak in phrases, altered mental status, cyanosis or severe accessory muscle use. Patient education and discharge planning. Successful asthma management extends far beyond the acute care setting. Patient education is perhaps our most important intervention. ASTHAN plan. Every patient should have a written action plan using the traffic light system. Green zone, doing well. Peak flow, 80–100% of personal best. No symptoms. Continue controller medications. Yellow zone, caution. Peak flow, 50–79% of personal best. Mild symptoms present, increase quick relief. Medication use, red zone, danger. Peak flow, 50% of personal best severe symptoms. Seek emergency care immediately. Home monitoring. Teach proper peak flow technique. Emphasize daily monitoring during stable periods. Recognize early warning signs. Maintain medication log discharge readiness. Peak flow, 70% of personal best, minimal or no symptoms at rest. Oxygen saturation, 95% on room air, able to demonstrate proper inhaler. Technique. Has written action plan and follow-up appointment. Key takeaways summary. Let's summarize the key points for nursing practice. Asthma is a chronic inflammatory condition requiring both acute management and long-term control. Your role as a nurse encompasses assessment, medication administration, patient education, and discharge planning. Remember the 3 pillars of asthma management. Control inflammation with appropriate medications. Avoid triggers through environmental modifications. Monitor response with objective measures like peak flow. Continue developing your expertise through asthma educator certification programs, professional organization resources, evidence-based practice updates, interdisciplinary collaboration. For additional resources, consult the National Heart, Lung, and Blood Institute guidelines, the Global Initiative for Asthma, and your institution's respiratory therapy department. Thank you for your attention to this critical topic. Your knowledge and skills make a real difference in the lives of patients with asthma.